All right. I think the theme of this morning's doctors is that they are all big ultrasound lovers. We had Dr. Wilcox pushing the ultrasound and how great the ultrasound was. And then, of course, Dr. Dickman. And Dr. Haney Mallemat is our next speaker, who is also a well-known ultrasound lover. We are just making sure that we have him on the correct link here. Brian, I think, is sending it to Haney right now. He maybe got on as a viewer instead of as a panelist. So while we get him on, I will tell you a little bit about him. He is the creator of the Critical Care Now website, which is a blog with all sorts of multimedia content on critical care and education that if you haven't checked out yet, you should. He's one of the few innovators right now using TikTok to bring medical education to the world, which is really fun. And he's a well-known national and international speaker. He practices both emergency medicine and critical care at Cooper University, but he really wants this audience to know that he is from Bayside, Queens. He trained in Brooklyn, and that New York City pizza is the very best pizza on the planet, and just try to prove him wrong. He's going to be talking to us about caring for the sick right ventricle. Let's just make sure we have him.
Just a quick note about our website while Dr. Mallemat is getting locked and loaded. You're able to sign up for, using your email, you're able to sign up for notifications so you know well in advance when we're having events. And also, especially if you want to be notified anytime we're having a basketball throwdown, so you can get your programs team up and running. One of the famous alum from SUNY Downstate, Kings County, EM-IM, Dr. Haney Mallemat.
Hello, how's everyone doing?
We're good, Haney, thank you.
Life's good, thanks for coming here. We're so happy to have you. I also agree that New York City pizza is beyond the best.
Absolutely, for sure. So are we running live? Want to do the talk? Ready to go?
Ready to go, no pressure. There's only approximately 770 viewers right now, but more because we know that we have a couple of residencies sitting live in a big open room together, so.
Wow, well, fantastic. Really, really good stuff. All right, well, let me get set up here. Just give me one moment to switch over screens. I have a certain way that I like to do presentations because we're all pretty zoomed out at this point. So let me get that all connected and let's see how that goes. All right, y'all can see me okay?
We are seeing you, but we are not seeing slides.
Oh, not yet.
There are slides.
Promise, they're coming
Oh,
soon.
okay, good.
All right, and I'll check in. So again, my name is Haney Mallemat. I'm an intensivist. I'm an emergency medicine doc, and I have a particular affinity for New York City. So anytime someone says, come to New York City virtually or in person, I'm always down. And so I also have a very high affinity for ultrasound and resuscitation. And the thing I'd like to talk to you about today is the RV. Now, I already know that none of you care about the RV. Believe me, I know that's true because I've given this talk before and I've seen the looks on the faces in the audience. I've scanned with residents, I've talked about the RV and fellows. And this is pretty much the look that I get every single time when I talk about the right ventricle. So hopefully you're seeing these slides because what I want to do is I want to take you through and talk about how to manage the sick right ventricle. The right ventricle is an underappreciated ventricle. Everyone talks about the LV. We got to resuscitate the LV, fill the LV up. No one pays any attention to the RV. And hopefully by the end of this talk, you'll have a much deeper appreciation for the right ventricle. And we're only going to talk about two things during this talk. We're going to talk about how to visualize the RV and how to assess it. And then we're going to talk about how you manage the sick right ventricle. So let's get right into it. Let's talk about checking out the right ventricle. Now, for those of you who do ultrasound, this will be a very brief review on how to do it. But the RV can be seen in all four of the views that you scan in. But the one that I want to focus on is the mitral level view of the parasternal short axis view. Here's the normal scan as you see here. You see that the LV is concentric. And the septum, the interventricular septum, is always concave with respect to the LV. This is normal. And as you scan patients and you start to see flattening, the D-shaped septum, as they call it, of the RV, you'll notice that there's some problems. If you want to take it up a notch and really be good with ultrasound, When there's flattening during systole, you'll note that there's a pressure overload happening on the right side of the heart. And when there's flattening happening on the, when there's a volume overload, there'll be flattening during diastole of that interventricular septum. That's just like some bonus pearls. But just know when you see flattening, there's some abnormality on the right side and you should pay attention to it. As we move on, we'll talk about the apical four-chamber view. This is the best view to compare the RV to the LV side by side. And what you're going to do here, and this is a normal view again, just to get your feet wet here, is the RV should always fit inside the left ventricle. Normally we say that the RV should be 2/3 the size of the LV. But again, I like that, just being able to visualize it going into that LV as normal. And then of course we have gradations of abnormalities. If it's between 2/3 but not quite 1-to-1, then we think that that's mild dilation, as you see right here. Once the RV is the same size as the LV, we think about moderate dilation of the RV. Again, these are all abnormalities that should make you think that there's a problem. And when your RV is bigger than your LV, kind of like where you're like, is my probe marker turned one way or the other? That's when you think that the RV has severe dilation. Now, it's not enough just to know that the RV is big. You'd like to know what the systolic function is. Now, I'm going to give you a term. If you really want to be smart and academic and walk around and alienate everybody with ultrasound, I want you to start using the word TAPSE. And TAPSE is essentially looking at the RV function. Now, the LV contorts in like 6 different dimensions. The RV is very simple. It goes in one dimension like an accordion. It goes from the base to the apex and contracting. And so that's why I use this term TAPSE, which is tricuspid annular plane of excursion. Don't even remember what it stands for. Just say TAPSE and you'll be a badass. But what you want to do is you want to focus on the free wall, the free annulus of that right ventricle, of that tricuspid valve, and watch it move up and down. So as you see here where the star is, you're looking right at that lateral annulus of the tricuspid, watching it bounce up and down. The more it bounces, the more normal it is. If you want to remember numbers, greater than 17 millimeters movement from diastole to systole is normal. Less than that indicates that there is systolic dysfunction. But just remember, tricuspid annular plane of systolic excursion. Here's just a quick example of an RV that's not performing well systolically. And you can go ahead, you can measure this with M mode, things I won't bore you with, but you can just eyeball this and say, this is a low systolic function with a big RV. There's a problem on the right side of this heart. Now, for those of you who have scanned many hearts, you might see a big RV, but it's performing well. And you're trying to figure out whether or not that RV is acutely dilated or chronically dilated. So people with COPD, pulmonary hypertension, they may have chronically dilated RVs as the RV has built up muscle over time trying to accommodate for that pulmonary hypertension. Well, the way you're going to do this is you're going to go to your subcostal view. You're going to get that good subcostal view, and what you're looking for is the free wall of that right ventricle. For those ultrasound nerds out there, you just want the beam to be perpendicular to the surface that you're measuring. And then you're going to freeze during diastole, and you're going to measure. The measurement you're looking for is 5 millimeters or less. That is a normal free wall of the right ventricle. The RV is not as strong. It's kind of puny compared to the LV. So 5 millimeters is all you're looking for. And if you have somebody, just as you see here in the star, if you have somebody who has RV dysfunction, then you're going to be seeing something like this, a big, thick-walled free wall. Now, I misspoke. It's not actually dysfunction. You have a large RV with increased size of the free wall during diastole. Anything over 5, so 6, 7, 8 or more, tells you, yeah, this RV is big, but it didn't just happen today. It's not like an acute PE. This RV is getting dilated over time and getting stronger over time because it's dealing with increasing pressures. So just keep that in mind when you see a big RV, the next branch point on your decision tree, is it acute or chronic? Do that subcostal view, look at the free wall, and then you'll make your determination from there. So let's move on and talk about the sick RV. Now, this is really important when you're doing resuscitation. We're talking about things where people come in with PEs, or they have acute on chronic pulmonary hypertension. The headlines these days are people with COVID. Severe hypoxemia alone could cause pulmonary artery vasoconstriction that can lead to a dilated RV. Any one of those pathologies is going to lead you into the RV death spiral. And this is really important to understand conceptually because when we go to resuscitate the RV, we're going to be keeping these things in mind. But let me walk you through the death spiral. So whatever the insult is, you're going to have an increase in RV afterload. So if you have severe hypoxemia, we'll stay with that COVID example, you're going to have pulmonary artery vasoconstriction. And what that means is that puny RV is not going to be able to squeeze against that increased resistance. So what happens is that RV dilates. When that RV dilates, what happens is it doesn't allow perfusion. Get this back up online. It doesn't allow perfusion of the coronary arteries, which are perfusing through the myocardium. So as it dilates, it doesn't like this slide at all. So I'll just talk it through. How's that? So as it dilates, as that RV dilates, the myocardial fibers are squeezing the coronary arteries in there. And now you can't get perfusion to the myocardium. And what happens? The myocardium becomes ischemic and it doesn't pump effectively to the LV. And when it doesn't pump effectively to the LV, what happens? Well, you get a decrease in cardiac output. And if you don't get an increase in cardiac output, you get a drop in your mean arterial pressure. A drop in your mean arterial pressure means your coronaries aren't filling, and that leads to further dysfunction of the RV, and that cycle continues on, and that's the death spiral. So you want to break that death spiral. So how do you do it? There's two ways you resuscitate the right ventricle. I want you to think about this framework. This is the 30,000-foot view. We're going to think about resuscitating the right side of the heart, and we're going to talk about minimizing hypotension. So let's talk about the right side of the heart first. Your goal is when you find a big dilated RV and you think that's the problem, is to start to augment the preload. What I mean by that is you can consider giving those patients fluids, but this is not the situation where you're going to give bolus after bolus after bolus. The RV Starling curve is very different than the LV. The RV can't tolerate lots of fluids at baseline, let alone when it's sick. So you can try giving small aliquots of fluid. I like to give 250 at a time and see if that makes things better. And I certainly wouldn't exceed 1 liter for these patients. Every patient's different, but I'm just giving you a global approach to it. So I'll try increasing the preload a little bit. My next step, and the step I'm going to be relying the most on, is to increase the squeeze of that RV. I'm going to increase contractility. That RV is down. I want to push blood forward, which is going to avoid that death spiral. So we increase contractility. Sometimes that's not enough. You need to also increase the afterload in the pulmonary artery vasculature. So we want to increase the squeeze and also at the same time vasodilate. And you could use things like inhaled nitric oxide or ibuprostanol, inhaled milrinone. Some people even use inhaled nitroglycerin. So there's lots of different ways you can vasodilate. The next thing that you can do that will minimize that afterload is to make sure that you are minimizing hypoxemia. Hypoxemia causes a reflex vasoconstriction. So give your patients ample oxygen, right? Give them whatever it is, high flow or non-invasive. Make sure that you oxygenate these patients well. The other thing we want to minimize is hypercarbia. Normally with COPD patients will tolerate some hypercarbia, but remember when they get hypercarbic, they become acidotic, and that causes pulmonary artery vasoconstriction. Okay, so before we leave the RV, quick review. We want to increase the preload a little bit, but not too much. We want to increase the squeeze of the heart while we're increasing the dilation of the pulmonary artery vasculature. That's going to make blood move through that right side to the left side much easier. The next thing you want us to consider is minimizing hypotension. Now you will see these people and you'll have this inkling like you want to intubate them. Try to fight that urge because as we all know, intubation leads to hypotension. Some studies say in up to a third of patients who are critically ill. I'm not saying don't intubate patients with pulmonary hypertension, but be sure you move through all these steps first before you intubate them. Because when you intubate patients, what happens is they become hypotensive, and then we go back to that side of the problem, and we're increasing the afterload on that RV. So we want to wait as long as we can to minimize intubation for these patients. Now, if you do have to intubate these patients, there's a strategy to this. And many of you are familiar with minimizing the amount of sedation you use for patients when you go to RSI them, because any sedation, even if it's ketamine, is going to cause hypotension. So giving smaller aliquots of your sedative hypnotic to get them ready for intubation would be a wise move. The best move would be to do an awake intubation where you topicalize them. But in the case you can't do that, minimize your sedation until they dissociate. And I say dissociate because I like to use ketamine, and then give full dose paralytics for that patient. Before you make that move to intubation though, I would get this person fully resuscitated. What I like to do is I like to use vasopressors, and my preference is actually to use vasopressin first. The reason why I say vasopressin first is because vasopressin is the least pulmonary artery vasoconstricting of all the vasopressors. Norepinephrine is pretty good, but still causes pulmonary artery vasoconstriction. Vasopressin causes peripheral vasoconstriction, where you want it to be, but not as much in the pulmonary artery. Things like neosynephrine and dopamine, if anyone's using dopamine, cause pulmonary artery resistance. And that's the antithesis of what we're trying to do. So if you're gonna get ready to intubate them, start them on vasopressors, vasopressin or norepi first. The other thing I like to do before intubation is I like to place an A-line. Now, people say, we gotta RSI this person, we gotta RSI them. But if you don't know what that person's blood pressure is, you can't respond to it. If it's dropping, you have to wait for that cuff to cycle. So if you have the ability to get an A-line in, get that A-line in, and then know what your blood pressure is as you're going to intubate them. And then the last thing I'll say is that for your ventilator, be sure that you minimize the settings on your ventilator, because the vent can also cause strain on the RV. PEEP, too high of tidal volumes, hypoxemia, hypercarbia can again affect that right side of the heart. So when you set your PEEP, set it to the lowest amount possible that will get you oxygenation, and try to minimize your FiO2 just at that point where you're getting good oxygenation. But if you need to give them more, because remember, hypoxemia causes vasoconstriction. If you remember all these things, you will have much more success resuscitating the person with the sick RV. But don't forget to identify that person first. And then once you've identified them, avoid them from going to that RV death spiral. I really want to thank you all for your attention. Please don't hesitate to reach out to me. I'm on social media at Critical Care Now, but thank you for the invitation. And it's always good to come back to New York, even if it's virtually.
Thank you so much, Haney. That was outstanding. We had actually a couple of questions from the audience that I was wondering if you could address. The first was a comment from Dr. Pik Mukherjee, who asks, Haney, did you just say nitroglycerin to increase afterload? Vasodilators? I'm confused.
If I said increase afterload, my apologies. Inhaled nitroglycerin, which I have no personal experience with, but Josh Farkas has talked about, and Sarah Krager, I believe as well, giving it inhaled can cause pulmonary artery vasodilation. Pulmonary artery vasodilation. You get systemic when you go intravenously. Inhaled can possibly cause pulmonary artery vasodilation, which again is the name of the game.
Amazing. Thank you for that. Also, from the vast internet, we have T-Serb, who asks if you titrate vasopressin or if you're using it as at a fixed rate.
Yeah, people ask this a lot, and you know, the study that went at you know, we used to use 0.04, now we're down to 0.03, and people think it's this fixed rate thing. There's no rules. You do what's right for the patient, and I will titrate vasopressin if I find that it's a vasopressor that people respond to. So this is kind of a departure from what I'm talking about generally, but everyone thinks it's norepinephrine first and vaso, and usually that's the case, but it doesn't always work that way. There are patients that are vasopressin depleted, and you don't know until you try. So if I get to my mid-range, like I call that like 15 or 16 of Levophed, I'll start vasopressin. And if the Levophed requirements or the norepinephrine, we got to be academic, comes down, then what I'll do is I'll stick with vasopressin. And when I get them off the levo, I'll titrate down the vaso, if you know, as they tolerate it. But just know that there's no rules. You can do whatever you want in critical care as long as it's right for the patient. The most important thing is to listen to the paper, not listen to what people have said before.
Amazing. All right, everyone, you've heard it from the expert horse's mouth. There are no rules. Seems like critical care would have been a better career for me and many of the other people I know on this cast today. Thank you so much, Haney, for joining us. You always really exceed our expectations, and I always learn something new. I look forward to your next TikTok dance. And again, Critical Care Now on Instagram. Immediately follow. You won't be disappointed. Whew, how about that? That was a